Today we are going to talk about acute rheumatic fever. Acute rheumatic fever usually affects children, and this is endemic in parts of Asia, Africa, and South America. That is the developing regions. It is a disease of developing regions, and this is important because as the hygiene and cleanliness will improve, this disease has been shown to vanish. It is very common in Australia as well, in Aborigines, in Asia, Southeast Asia, particularly India, Pakistan, Africa. Now it is triggered by an immune-mediated delayed response to infection with specific strains of group A streptococci. All the words are crucial there. That's a delayed response. The group A streptococci. So what happens is that the antigens of streptococcus are almost similar to the antigen in cardiac myosin and sarcolemmal membrane protein. So what happens that our body immune system is tricked into thinking that the antibody which it is producing against the streptococcus, the same antibodies also cross-react against various parts of heart and joints. So this phenomenon is also called molecular mimicry. It is important to remember that which organs are affected: skin, heart, and joints. So it's a multi-system disorder that usually presents with fever, anorexia, lethargy, and joint pain. The latent period is 2 to 3 weeks after an episode of streptococcal pharyngitis. That is, so you will have sore throat followed by 2-3 weeks later you will have uh, fever or arthralgia. The diagnosis is made by revised Beckett-Jones criteria. So this is often tested on exams. It has two major and one minor, two or more major, or one or more major with two minor manifestations, along with an evidence of preceding streptococcal infection. Either that might be a swab or an antibody titer. We will discuss it along with. So the revised Jones classification, these are the manifestations. Carditis, generally it is pancarditis. What does pancarditis mean? It will involve heart, endocardium, myocardium, and pericardium as well. And polyarthritis, note this is polyarthritis, not polyarthralgia. Polyarthralgia is a minor manifestation. So you will have you will have to document the swelling, not only tenderness or chorea. Chorea is an involuntary movement. Then erythema marginatum, that is the evanescent fleeting mark. The subcutaneous nodule, which is a painless nodule. The polyarthritis is generally migratory. That is, involves a bit of bigger joint and goes on from one joint to other. Minor manifestations, these are fever, arthralgia, previous episode of rheumatic fever, the PR prolongation greater than 0.2 seconds, leukocytosis, raised ESR or CRP. How do I remember it? Major manifestation I remember by CH acne. CH for chorea, A for arthritis, C for carditis, N for nodules, E for erythema marginatum. How do I remember minor manifestation? I remember by FAPR. So F for fever, A for arthralgia, PR for previous rheumatic fever, PR prolongation, and APR, acute phase reactant. And plus there has to have supporting evidence of preceding streptococcal infection. So it can be ASO titers. You can have a positive throat swab. So, and if you have only one major manifestation, then it is important that you get a throat swab or an ASO titer. So this is very important. So I have dealt here with mnemonics of major manifestation, minor manifestation. This is often tested. Let us talk about the carditis thing. The carditis will involve the endocardium, myocardium, pericardium to various degree. So if you have the myocardium involved, what will happen? Myocardium, that is the heart muscles. So obviously you will have signs of heart failure. So what are the signs of heart failure? You can have tachycardia, you can have breathlessness, can have cardiac enlargement. What about the endocardium? When you have endocardium involved, so you will have valve abnormality. So you can have murmurs, right? The valves will start leaking. So valves, so you have a mid-diastole, carry comb tracker. So you have an AR, aortic regurgitation. All sorts of regurgitation will take place. Classically, the murmur is called carry comb murmur. So AR or MR, regurgitant murmurs are pretty much common. AR is classical aortic regurgitation. Then if you have pancarditis, what will happen? You will have definitely if you have pericarditis, what will happen? Pericarditis manifests as pericardial rub, or you will have chest pain. So these are the various manifestations. ECG, you will have PR prolongations, and ST and T wave changes, which are classical of pericarditis, might appear. What are the ECG changes in pericarditis? So you have generalized ST elevation with no reciprocal ST depression. Now the incidence will decrease with increasing age. So 90% at 3 years to around 30% in adolescents, and it is uncommon in adults. Arthritis, it is most common early manifestation. So acute painful asymmetric and migratory inflammation of the large joints is very common. So it is involved in large joints, not in small joints. Knees, ankles, elbows, and wrists will be involved. The pain is classically responding to aspirin, very high doses of aspirin. And it is important, if the pain doesn't respond to aspirin, the diagnosis is in doubt. Nowadays, they are using naproxen as well. The erythema marginatum, this is pretty much uncommon, particularly in our scenario, because it is more often noticed in the white Caucasian population. The lesion starts as red macules that fade in at center but remain red at edges. That is why erythema marginatum, they become red at edges. Important, doesn't involve face but mainly occur on trunk and proximal extremities. Subcutaneous nodules occur in 5 to 7% of the patients. In firm, painless, over extensive surface of bones or tendons, and generally appear 3 weeks after. So important, nodules and chorea, these are late manifestations. So these are able to confirm the diagnosis, not to make the diagnosis. The diagnosis will be made either generally by fever with sore throat, polyarthralgia, polyarthritis or arthralgia plus minus carditis. Nodules, chorea, these are late manifestation. Erythema marginatum is common in whites Caucasian population, not in our population. These are the some of the figures. You can see the nodules. You can see the erythema marginatum. You can see the marginate edges. This is chorea, St. Vitus dance. Now, this is a late manifestation, appears at least 3 months after episode of acute rheumatic fever. Generally, by this time, all signs of disappear. So, and this is involuntary. There is emotional breakdown as well. Speech may be explosive and halting, and spontaneous recovery occurs within a few months, though sometimes drugs like haloperidol are also given. So you can do an ESR or CRP to monitor the progress of the disease. Important, positive throat swab cultures are seen in only 10 to 25% of the cases. So how do you make a diagnosis? You do a ASO titer, which is higher, generally greater than 1:200. raised ESR, CRP, and clinical feature plus revised Jones criteria. How do you document the cardiac damage? Obviously, some by clinical examination and other with echocardiography. As I said, no stenosis, only aortic regurgitation and mitral regurgitation is pretty common. Investigations, pretty easy. For evidence of systemic illness, you will do CBC, complete blood count, where you will see fever, high TLC, high CRP. Then you will have an evidence of preceding streptococcal infection, either by ASO titer or by a throat swab. As I told, it is positive in only 20% of the cases. And then you will document the evidence of carditis either via X-ray, ECG, or an echo. How can you manage? So there are two strategies: management of acute attack, management of current infection, and prevention of further infection and attacks. So if you have the acute attack, you give a single dose of benzathine penicillin, that is 1.2 million units IM. Many times, if the patient is penicillin allergic, you can also use erythro or azithromycin, though benzathine penicillin is better. How do you treat with the pain, the arthritis? You generally give it high dose of aspirin. Right? It is not normal 325 mg is not daily. You need it in grams. Generally 3 to 4 grams. You can also take help of naproxen, though, which is which has lesser side effects. Then, as we know that the major organ involved is the heart, right? So then we try to treat the heart damage and relieve the symptoms. So if you have heart failure, you can give diuretics or other drugs, and you hope that the patient doesn't have residual damage. Then you have bed rest and supportive therapy. And if you have heart involvement, be patient in returning to the normal activity. So this is important. Cardiac failure, mild heart failure. So when do we use steroids? When you have mild heart failure, you can give it. You can use steroids. Severe carditis, you can use digoxin, but generally digoxin is not preferred. As I said, vasodilators and diuretics also might be used. But if the heart failure doesn't respond acutely, what should you do? You can give. You can have to do a valve replacement. As I discussed it earlier, if you have protected Sydenham's chorea, it will require long-term antimicrobial prophylaxis. Even if protected Sydenham, which will generally respond to haloperidol. If you have carditis residual damage, then it will require long-term antimicrobial prophylaxis, which I will discuss. And complete physical and mental rest is essential, because in chorea it is aggravated by very emotional events, right? So patient will start shouting or doing things in a very explosive fashion. So as I told, that aspirin is a very high dose, 60 mg per kg. In adults, even till 8 gram per day. Aspirin should be continued till the ESR falls. So this is how we judge the treatment. Okay. Then steroids, as I told, that they have rapid relief than aspirin. Okay. Generally useful if you are having heart failure, as I told you, which can be in addition managed to with diuretics. And ESR, we monitor the treatment with ESR and obviously clinical signs. Okay. So, but suppose if how do you treat and manage? So, if prevention primary, you can, if you have sore throat, then automatically in children, then please give penicillin therapy. And if you don't have penicillin, at least give azithromycin or something like that. Okay. So treating sore throat is very important. Not neglect, because particularly in children, because it can go on to develop rheumatic heart, acute rheumatic fever or rheumatic heart disease as well. Secondary, when there is substantial risk of recurrent acute rheumatic fever, so you have to prevent it. Okay. and and or if there has already been a heart damage, so you will have to prevent it by taking regular courses of penicillin. It is not to treat but to prevent. Okay. uh, then Primary prevention, ideally, that is, it involves eradication. As I told, every sore throat has to be, ideally throat swab should be done. If you are not able to do a throat swab, do a titus and give penicillin. Secondary prevention, as I already told, that long-term prophylaxis, you have to take in 3 weekly benzathine penicillin IM doses. If it is not available, you can take oral phenoxymethyl penicillin 250 mg 12 hours. Even if that is not available or that there is allergy, you can take erythromycin or azithromycin daily 250 mg per day. Sulfonamides are not effective in eradication. This is very important. In many emergencies, you will see the patients will come for regular therapy. Now, this is a question which is often tested. Secondary, what is the duration of secondary prevention? So, if you have rheumatic fever without carditis, then the duration is at least for 5 years or until age 21 year, which is longer. What does it mean? That uh, if you don't have any heart damage, you have to take the monthly injections or the oral doses daily till 21 year or at least 5 year till the after the last episode. With carditis without residual heart disease, that is for 10 years. That is, you on an echo, you had an involvement of heart, but no longer, which the echo after 2-3 months is normal, then you can take it to 10 years or well into adulthood, whichever is longer. But if you have residual heart damage, it is said that you should at least take it to 40 years or at least 10 years since last episode. So you can see the ladder of the risk. Without carditis, 5 years. With carditis, without residual disease, 10 years or in adulthood. And if you have residual heart damage, there is a rheumatic heart disease, then take till almost till 40 years. That is the longest period. Complications, as I told, that you will have regurgitation. Not stenosis, but regurgitation.